Hey everybody, it's Dr. Shawn Tassone, America's Holistic Gynecologist, coming at you from Austin, Texas. I am the author of the Hormone Balance Bible, which you can get on Amazon. It talks about the top 12 most common women's hormone imbalances through perimenopause, menopause, and even younger age. And it really puts the 12 most common imbalances into a perspective with stories and archetypal language to allow you to better process the information and to help you get through the confusion that kind of surrounds hormones. You can find me on Instagram, Shawn Tassone MD. You can find me on YouTube. Maybe you're listening to me now, Shawn Tassone MD. And the whole purpose of my platform is to try and educate, to expose fraud, to hopefully help you understand hormones, to ease your mind about hormone replacement, and to really cut through some of the issues that women face with hormones. And the topic that I wanted to talk about today is postmenopausal bleeding. And the reason that I want to talk about it is I probably get questions on this daily through my patients. I do see patients in Austin, Texas. I'm currently licensed in about 42 states. So I do a lot of telemedicine. I see women all over the country. And I start women on hormones all the time, women that maybe have never been on hormone replacement, older women, maybe in their 60s and 70s, even 80s, that are just new to hormone replacement. And I do get a lot of questions about spotting, bleeding, endometrial polyps, what to do, how do I handle it, things like that. So I just kind of wanted to give you a basic understanding of postmenopausal bleeding. Now, whenever you start hormone replacement, let's say we're talking about menopause in this episode simply because I'm talking about postmenopausal bleeding. So bleeding in women that are menopausal. Now, let's say you have postmenopausal bleeding and you've never been on hormone replacement. You're not on hormone replacement. As a general rule, OBGYNs and even general practitioners should always think that it's cancer until proven otherwise. We want to make sure that no woman ever dies of uterine cancer. And the reason for that, other than the obvious, is that uterine cancers will tell you that they're there. And the way that they tell you that they're there is by abnormal bleeding, especially in women that are in menopause. So if you haven't had a period for years and then all of a sudden you're bleeding, then that needs to be investigated. So let's talk about women that have never been on hormones because that's kind of an easy one. You call your doctor, you're having some bleeding. Now, we may look at that and go, well, if this is a new finding, it just happened, it was for a day or two, maybe we don't have to worry about it. In those doctors that are a little bit more conservative, they may just say, well, let's take a wait and see approach. If it happens again, let me know. That's not necessarily a horrible way to do it, and it gives you kind of some more time, lessens you being exposed to testing and whatnot. But if you have a doctor that's a little bit more aggressive, the first step that you should undergo when you're having postmenopausal bleeding is to have an ultrasound. And the reason that we get an ultrasound is there's a main reason and then there's secondary reasons. The main reason for getting the ultrasound is so that we can look at something called your endometrial thickness. Now, the endometrium is the lining of the uterus, and we often think of the uterus as having this cavity on the inside, like an opening. But when the uterus isn't pregnant, that the walls press up against each other. So it's a potential space, meaning that it's not necessarily filled with air or fluid or whatever. And so when the sides of the uterus are compressed together, the thickness we can measure. We can measure the thickness of that endometrial stripe. Now, in postmenopausal women, we want that stripe, is what it's called, to be under 5 millimeters. It's a pretty slim margin, but that's usually the accepted. Now, some doctors will use 3 millimeters. I use 5 millimeters. And we also are wanting to look for any sort of abnormalities, meaning, is there a certain area of that endometrial stripe that's thicker, like up at the top or at the bottom? Are there weird findings or common findings like fibroids? Because all those things can cause bleeding. So let's just say we have an endometrial stripe that's say 2 millimeters, very, very thin. The suspicion at that point for uterine cancer is pretty low. Now, again, you could have a doctor that says, well, the endometrial stripe is really thin. That makes me feel a lot better. Let's watch it. Let's repeat it, especially if you have bleeding again. But let's repeat it in, say, 8 to 12 weeks. If it's getting thicker, then maybe we'll do something different. If it looks like there's a polyp or something, or if you continue bleeding, then the next step is something called an endometrial biopsy. An endometrial biopsy strikes fear into a lot of women because of potential pain and things like that. Now, keep in mind, an endometrial biopsy could be a life-saving test if you do have precancerous cells or cancer. And the reason being is that because if we catch a uterine cancer at stage 1, which is usually where they should be caught, then you are basically saved with a hysterectomy. It's gone. You don't ever have to worry about it again, and you can live your life. The endometrial biopsy is a thin plastic pipelle, and it's probably 1 to 2 millimeters in width. And can it be painful? Indeed, it can. As with like dental visits and anything else, everybody's pain tolerance is a little bit different. Some women, it can be exquisitely painful. Others, they tolerate it just fine. But you should never go into a test like that fearing that the doctor is going to hurt you. And I'll tell you why, because they should be open to helping you get through that. Now, there's different ways to do this. The reason for the pain, twofold. One is that in older women, say 60, 65, who haven't had a kid in a long time or a period, the cervical os or the opening into the uterus can be what's called agglutinated, meaning it's kind of sealed shut. Hasn't been opened in a long time. You haven't had bleeding for a long time. And so the opening just kind of becomes stenotic and it closes. And when you try to push past that, it can be pretty painful. The other thing is, if your uterus, if the cervical os is open and the pipelle passes, no uterus, well, shouldn't say no, but not many uteri are straight, meaning the pipelle is straight. So you just push it in and it goes right in. Most uteri are what's called anteverted, meaning they kind of bend towards your bladder. About 20% of uteri are retroverted, meaning they bend back towards your spine. And so if you try to shove a pipelle in and you shove it in straight, but the uterus is curved, you're going to grind all the way back up that endocervical canal, and that can be exquisitely painful. I try to pre-bend my pipelle so that it goes in a little bit easier. I have done thousands and thousands of endometrial biopsies. Now, the goal with any procedure should be to limit the amount of pain. And we all know that women's pain levels tend to get diminished in the medical arena. We tend to minimize women's pain and we tend to minimize women in general. And so you may feel hopeless. Now, can a doctor do something to make this endometrial biopsy a little easier? We can. We can try a couple things. You can try what's called Cytotec. Cytotec is a medication. It's a prostaglandin. Prostaglandins make you contract. So sometimes I'll have a woman take Cytotec the night before the test and then the morning of the test, because that contracting can kind of open up that endocervical canal and make that pipelle passage a little bit easier. You could take ibuprofen prior to the procedure. Ibuprofen helps with pain, obviously. You could also ask for what's called a paracervical block. A paracervical block is basically lidocaine, just like you would get at the dentist's office. And we have a long needle called a spinal needle, so we can reach up to the cervix. And we give you injections in the areas where the nerves come into the cervix. The nerves tend to generally come in around 3 and 9 o'clock. So we really numb those areas up really well. Now, usually that will help. The problem is, sometimes the injections hurt almost as much as the endometrial biopsy. So we're giving you 2, 3, 4 injections sometimes, and when we could have just done the pipelle. So I don't want people to think that the reason that we don't give injections is simply because we're mean. Some of us who have been doing this a long time have come to realize that the injections can hurt more sometimes. So, but it should still be offered to you, and you can make that decision. Usually, it's, on a scale of 1 to 10, at least in the experience that I've had with my patients, it should be somewhere between a 2 and a 6. and it's very temporary, meaning it goes away. Now, if you don't like that potential, then you ask for an endometrial or a paracervical block, and we try to inject that cervix with numbing medicine, basically lidocaine. It should be without epinephrine. Epinephrine causes vasoconstriction when you inject it and can keep the numbing medicine there for a longer period of time, which you don't need for an endometrial biopsy because it takes about 30 seconds. But if you inject epinephrine into a patient's arteries, they can get this sudden rush of anxiety, and it can be pretty disabling because that epinephrine is that flight or fight response, right? So you can feel like you're coming unglued. So usually if a doctor is going to do a paracervical block, they should do it with like a lidocaine without epinephrine. And that is your right. And if your doctor won't do that for you because they don't think it's going to hurt, or they don't do that or whatever, then just have that discussion with them. What I always tell my patients is this: I'll give them the option, and then I'll say, look, I can try it. We can always try the biopsy. If it starts to be painful for you, and you let me know, I will stop. The goal here is not to hurt you, it's to get a diagnosis and to do it in the most comfortable way possible. So we started with postmenopausal bleeding. We got an ultrasound. If the ultrasound comes back with a thickened endometrial stripe, or it has a normal endometrial stripe, but you're still bleeding, then we're going to want to do what's called an endometrial biopsy. Now, the endometrial biopsy can come back with certain results. It can come back as normal. It can come back with fragments of a polyp. It can come back with proliferative or hormonal changes, meaning if you're on progesterone, then the lining can look like you have a progesterone effect from the progesterone. It can come back with what's called hyperplasia. Hyperplasia is kind of an abnormal cell that's growing rapidly, and in a woman that's postmenopausal, that shouldn't be happening. Now, there are 4 steps of hyperplasia. There's simple hyperplasia. There's simple hyperplasia with atypia, meaning the cells are starting to look abnormal. There's complex hyperplasia, and there's complex hyperplasia with atypia. The magnitude of that diagnosis will kind of guide what we do. Now, if you're in your postmenopausal years, which is kind of what I'm focusing on, and you have any type of hyperplasia, 99% of the time, the physician's probably going to recommend a hysterectomy, only because, not that we're surgery happy or that we're mean, it's just because we know that that will fix the problem forever. You don't ever have to worry about it again. Now, if you have something called simple hyperplasia, and maybe you're 50 or 45, you might have a doctor that recommends progesterone, high-dose progesterone therapy, because high-dose progesterone therapy can indeed thin the lining out and get rid of the hyperplasia. But you will be required to probably have more endometrial biopsies and more ultrasounds. That could be an imposition on your life and your pocketbook. So it's really, those are the options. So what is an endometrial polyp? Let's say the results come back as an endometrial polyp. A polyp is kind of like a skin tag. You hear about polyps in the colon when you have a colonoscopy that can eventually turn into cancer. And the reason is polyps are kind of those tissues that are growing aberrantly, meaning they're growing a little bit more and a little faster than regular tissue does, and it's forming this growth. Think of it like a skin tag that you might get on your skin somewhere. 95% of the time they're benign and they're not a problem, but they're composed of basically blood vessels, capillaries. And so polyps bleed a lot. That's just what they do. And so if you keep bleeding, it would make sense to remove the polyp. The problem with an endometrial biopsy, or that sample of tissue that we take, is that it's blind, right? Because we're putting this pipette up in your uterus and we're moving it around, but we can't see anything because it's inside the uterus. So it's a blind biopsy. So we may not get everything that we want to get, or we may miss something. So your doctor, if you have an endometrial polyp, might recommend what's called a hysteroscopy. Hysteroscopy is where we take you, some doctors will do it in the operating room, some will do it in their office. We put a camera in the uterus and we fill the uterus with fluid, usually normal saline fluid. And that will then make the polyps float, and we'll see them because they'll be visible. And then we can use a little device through the hysteroscope, and we can clip that polyp off. Some doctors may recommend that you also undergo something called an endometrial ablation at the same time, which is after we clean the lining of the uterus out, remove all the polyps, we heat the lining of the uterus up for about 90 seconds to cauterize the inside so that that stuff doesn't usually grow back again. Many women that are younger have had uterine ablations for heavy, painful periods or polyps or whatever, but your doctor may recommend that hysteroscopy and what's called a dilation and curettage, where they clean it out, or the endometrial ablation. Let's say you have a fibroid. Fibroid's going to be a little bit different because there's different types of fibroids. There's subserosal, meaning it's like growing on inside your kind of like your abdominal part of the uterus on the outside. Those usually don't cause bleeding because they're on the outside of the uterus. The ones that we really worry about with postmenopausal bleeding are the submucosal ones, which are kind of bulging into the cavity itself. Now, again, if you have one of those and you're bleeding, your doctor might recommend a hysteroscopy where we actually go in with the camera and then we try to cut out or trim down that fibroid and make it flush with the cavity, and then maybe do an ablation again. So there's different options. There's different things you can do. And I will get a lot of women who say you're 58 and you call my office. You've never been on steroids or hormones before. And you're on them for about 2 or 3 weeks. And what are the side effects of hormone replacement therapy? Breast tenderness, nipple sensitivity, are the two big ones, sometimes bloating. But something you can also get is spotting. Now, in the first few weeks of using estrogen and progesterone, spotting is very common. I probably see it 30 to 50% of my cases. It's usually self-limited. It's usually just spotting, not like a full-on period. That could happen as well. But it's usually just mild spotting. And if you can just ride through it, I get calls all the time, even though I tell patients, because it freaks you out because you haven't had a period for 8 or 9 years. But we like to just watch that. I usually don't order an ultrasound because we're just starting. We're kind of cranking the engines back up. We're starting things back up. So that lining is going to be stimulated. So it could cause some spotting. Let's say you've been on hormones for 2 years and you've all of a sudden started spotting. Well, that could be a couple of things. You could have a polyp, but you could also have just kind of an imbalance between your estrogen and your progesterone. So what's going to cause bleeding is going to be either the endometrial stripe is so thin that it's at the bottom of your endometrial lining, you have all these blood vessels. It's called the basilar area. And if those vessels get exposed because the lining is so thin, they can ooze. And so they'll just ooze. And it's kind of like when you cut yourself in the shower. You can't really put pressure on the inside of the uterus. So it oozes and oozes until it eventually clots itself off. And if you're active and you're working out and you're, doing all the things and lifting weights, those clots could come off and you could bleed again. It doesn't mean that there's anything wrong with you. It just means that these vessels are exposed. So it could be that maybe you're taking too much progesterone or not enough estrogen. And sometimes just thickening up the lining a little bit with a little extra estrogen or cutting back on the progesterone can help. And the only way to know that is to get the ultrasound to see what the lining looks like. Now, you could also have bleeding on the other end of the spectrum if your lining is too thick. And that would be over 5 millimeters, because the lining just starts to shed because it's too thick, or you have a polyp or something along those lines. That could be from too much estrogen, not enough progesterone, or it could be from something abnormal like endometrial hyperplasia that I talked about a little bit earlier. So the ultrasound can give us a little bit of information. The biopsy can give us a little bit more information. If everything checks out, let's say your endometrial stripe is 4 millimeters and you're having some spotting. Me personally, I probably wouldn't get too aggressive with that patient unless the bleeding continued. If the bleeding continued, I probably would recommend she either see her gynecologist or come into the office where I would do the endometrial biopsy. So you can see, while postmenopausal bleeding can be scary, or at least alert you to something being there, the doctor needs to know. And obviously, most women, if not all, will call me if they're bleeding because it's kind of scary. There's a lot of things women won't call me for, and they'll just try to adjust their dosages, like hot flashes, insomnia, things like that. But usually you're going to call if you have bleeding because you obviously know something isn't right there. So it's always good to call your physician if you have bleeding, even if it's in the beginning. I do tell my patients it's usually normal in the very beginning when we start HRT, especially if you're in that 55 to 75-year-old age group because we're starting the engines back up. But it's always good to get that checked out. And it's always good for them. This is the other reason why I check hormone levels, because I can see if the estrogen is high and the progesterone is low, or vice versa, by a blood test. And I can combine that information with the ultrasound. So for many of you, when your doctor tells you, oh, I don't want to get levels, I don't, what are we going to do with the information? Well, this is a really specific case where having those levels could actually be quite helpful for you and could help the doctor actually make some nuanced decisions. Now, are there going to be physicians out there that knee jerk, they just want to do an ultrasound and endometrial biopsy on everyone? Of course. But I would think most of the physicians that are out there today would use that technology sparingly, because nobody wants to undergo a procedure. Although those of you that complain that we are procedure driven, that we get paid more, that's true. You do get paid more for doing an endometrial biopsy. But I would venture to say that most physicians don't just go around biopsying people that don't need it. I think postmenopausal bleeding is an indication for a biopsy. You're not going to get one OBGYN that would say that that's wrong. But some of us might be a little bit more less of a trigger finger and might be comfortable watching for a little bit, because let's face it, cancers in general don't just happen in a month. They happen over time, usually years. Most theories are that like say for the instance in breast cancer, that it's probably been there for 2 or 3 years before it becomes detectable. So it's not like cancer just all of a sudden happens. It's a process, right? So let's look at this again. You're on hormones. You're postmenopausal. You're over the age of 51, 55. You're just starting out on HRT. You're having some spotting. You call the doctor. It's not abnormal for them to say, that's very common. I wouldn't get too concerned about it. Let's keep going for another couple weeks. And then if it happens again, obviously let me know. Step number 1, usually you're going to get an ultrasound. If the ultrasound shows endometrial thickening or potential for a polyp, they may ask you to come in to do an endometrial biopsy. Depending on what the biopsy says, would determine if the next step is a hysterectomy or a hysteroscopy, or just everything looks great, we don't need to do anything, let's just repeat the ultrasound. In a few months, we may change the hormones around a little bit, and see where things go from there. I wanted to do this episode because it's very common. I think there's a lot of confusion around what to do. I think there's a lot of fear, obviously. Women are still fearful of HRT, even though we know that it's very safe and effective and helps with a lot of other things. So I would encourage any of you, if you're listening on YouTube and you have questions, feel free to consult with me. You can call my office at 512-956-0296. You can follow me on Instagram or Facebook or wherever you get your information from. Remember, postmenopausal bleeding can actually be a good sign. It's an early detection mechanism. We want to make sure that no woman out there ever has or dies from uterine cancer. It's one of those cancers that's easily detectable early on, and it's something that your doctor should be following up on if you have it. I hope you all have a great day. I hope you all have a great weekend. I'll be around. I'll see you on the gram, as they say. Take care.